It's about 6:30. We're going to go ahead and get started with Grand Rounds. Good morning, everyone. So today we have our vascular Grand Rounds. And again, if you want to get CME credit, please text the number up here, 11718 to the CME number that you see here. And then we'll just have Dr. Singh come up and do our introduction.
Well, good morning, everyone. It's with great pleasure that I get to introduce Dr. Jason Lee, who is a personal friend, but a friend of our division. Dr. Lee hails from California. He's a true Californian. He went to Caltech for undergrad, where he was a consummate athlete and played on the tennis team and basketball team at Caltech, and then went on to UCSD for medical school. He then went to UCLA Harbor, where he, under the influence and mentorship of Christy Virgilio and Rod White, got interested in vascular surgery, and then went on to do his vascular surgery fellowship at Stanford under Chris Zarins and Ron Dahlman, and subsequently stayed on at Stanford and has been the consummate academic surgeon. Dr. Lee was program director for 9 years at Stanford. He has over 230 publications, 40 book chapters. He's been past president of the Vascular and Endovascular Surgical Society and the Association of Program Directors in Vascular Surgery. He is big on education, and he has worked a lot to change the education paradigm in vascular surgery, which has transitioned from that time period of just fellowship to having an integrated residency. And he's been instrumental in leading that change. And on another note, I will say that Dr. Lee, despite his athletic prowess, could not turn around the Caltech Beavers' 310-game losing streak that they had in the conference, or a 60-game consecutive game losing streak, which spanned 1985 to 2011. Despite that, Jason, you've done a lot of things and won a lot of things, but maybe not basketball. So it's with great pleasure that I introduce Dr. Lee. Thank you, Jason.
I don't know with that, maybe I should just talk about basketball today, but let's see. It's a real distinct honor and privilege for me to be here today to see a lot of familiar faces and friends that I've known over the years, but really these are the opportunities to get to know some of the new folks and to hear about what's going on. And I think you can't put too light of a touch on the fact that the University of Washington, particularly for vascular surgery, has been one of the starting points in the history of the specialty, particularly on the West Coast. And so numerous people that have influenced me have talked about, if you will, the hallowed grounds of this medical center, the helipad that I was taken up to yesterday, or I guess down to, because I just assumed, of course, it was on the roof like at most places, and then here I realized it's right on the ground floor and you wheeled straight in. And I've heard stories from one of my mentors, Ron Dahlman, about the times here at the University of Washington, people like Chief Strandness, and then people that are still here, Gene Zerler, and sort of the original, Mark Meissner, and then the folks that had set up the division. And then these are some disclosures. So it's really with some acknowledgements here that, I think really the University of Washington vascular system or sort of division was already quite well known sort of amongst West Coast folks. And I can remember as a surgery resident and, as a medical student, reading tons of papers about vascular labs and things set up like that. And then I'd like to say sort of, era 2.0 was my good friend Ben Starnes here, this is in a compromising photo that of course, it pops up on my phone. On your phone, every once in a while, you get what happened 12 years ago? What happened 14 years ago? And so this popped up on my phone, so I couldn't resist. Let's put this up here. But I've known Dr. Starnes since really being a vascular surgery fellow and spending some time at the meetings, and saw him as he sort of accelerated timelines of taking over as division chief, really at a young age. And Ben probably doesn't remember, we took a trip to Brussels, Belgium together for one of the meetings to have to debate about something aortic. And we got to spend half of the day kind of wandering out to this lake area, having a Belgian beer, finding some either a pretzel or chocolate or something. And he had just taken over a couple of years of being chief here. And I remember as a young faculty member at that moment asking, gosh, what's it like to to be in charge? What do you think the responsibilities? What are your fears and things like that? And it was always about when you're ready to make that step, it's about helping others and really championing the causes of, younger faculty, the trainees, the residents. And that always stuck with me, that time that we spent in Brussels, debating things over the years. And so I thank you, Ben, for 20 years of friendship related to that. Nitin Singh here, this is at the Vascular Annual Meeting just a couple of weeks ago, or a couple months ago. This is in New Orleans, and Nitin has been my close colleague and friend since we were on the Vascular Fellowship interview circuit together. And the time that we've spent and kind of grown up through the ranks together, figuring out how to make sure that we augmented education and challenging each other. I think, I hope that you all find colleagues at other institutions, that at the meetings, you get to know their families, you work with them, you collaborate on projects together, and you see when they succeed, you're happy for them, and you think, oh, I got to be able to try to do the same thing. And Nitin's been that person for me over the years, and really every time, committee-wise or society-wise or even personal-wise, when I've needed advice or whatever, I've called on Nitin to just ask him a question. And I hope that for the young people that you find those, core group of half a dozen to 10 people across the country where there's no judgment related to it, and there's no sort of competition built into it, because really it's just about free advice that's been given. So Nitin, I thank you and Heidi for years, for decades of friendship related to that. Okay, so I wanted to, the title of this really was something I thought that would be different for a sort of Department of Surgery audience. That was more, because I could spend the whole time talking about endografts and complex EVAR, or I could talk about popliteal entrapment and get just, 4 or 5 of you in the room intrigued, and then everybody else starts looking at their phone. So I actually kind of wanted to step back and just talk about our arc to something recently, the last 5 years, that I've spent a lot of effort on, and that was building our biobank. And I wanted to weave a story about sort of resilience, trying to do something scientific, perhaps being turned down, which is the story that I'll tell, meaning not getting funded, and then pivoting on that and finding a different way to continue with that passion and interest. And so then it ties into what's the academic surgical mission. And in 2025, we got a lot of issues in the country right now. That goes sort of without saying. And for the folks in the room that are chasing after NIH dollars, I encourage you to keep chasing after those. I mean, those are few and far between, but that's what constitutes the difference between places like UW and Stanford from everybody else, is because of this academic surgical mission. So that's the story I wanted to weave today. I think, folks, unless you've been with head in the sand, then you've realized that our specialty has converted to kind of an endovascular based specialty. And I think that all of the current younger trainees realize that and have embraced that. And so while people may have niche practices where certain parts are more emphasized than others, it's clear to me, and this is a paper we had presented at the Pacific Coast Surgical over 15 years, or over 13 years ago, about the transition from what a vascular trainee's portfolio they submitted to the American Board of Surgery looked like. And here, back in 1999, look at that, it was like 99% open cases. And so people like Dr. Singh and I got to live through our practice of that transition. And, I'd say kind of on average across the country, it's probably about 50-50 now. And I think even here, so some people swing a little bit more, mainly endo, or some people swing towards mainly open. And then this was a paper, then the sort of inevitable consequence of that is educators then wonder, well, what do we do about open surgery then? How do we teach that thing? And I know University of Washington, with the history of Dr. Pellegrini here, lived through the laparoscopic change, and somebody like Dr. Pellegrini, who I had the chance to visit with as part of the ACS educator when SIM centers were all being certified and stuff. That's when I first met him. I think people would always ask that question. What are we going to do one day when people can't do an open chole, when people can't do an open common bile duct exploration? You know what it turned out? They figured out how to do it laparoscopically. And that's what in this transition to sort of endo, we've forced ourselves while sort of maintaining some of the open skills or finding creative ways to learn those techniques, still became important to let the specialty evolve and sort of improve. I think folks who know me know that I'm super interested in sort of endovascular aortic repair. There's a lot of the pioneering sort of observations were from folks practicing here, and some of the things figured out over the years. These are currently the FDA approved devices for standard infrarenal aneurysm. So even sort of the general surgeons in the room and in the audience know that, you know, way back in the day before vascular surgery was its own thing, during surgery residency, I think most people remember doing an open infrarenal aorta and putting a clamp on. And that was really for a lot of the medical, or when you're in medical school, when you see that, that's probably the reason why you go into vascular. Like, that day is gone now, and I hope the med students that are influenced to go into vascular, it's because there's some complex endo thing that has been planned, and they're understanding kind of the nuances of planning and the creativity that comes with that. This is our volume of sort of open versus endo, and everybody has graphs like this really to just sort of indicate that the 2000s were really this transition time where folks like Neil Olcott, that a couple people in the room know that had trained me. You know, Neil retired in 2006. And that's when, you know, most centers were still doing a reasonable amount of sort of elective open aneurysm. And then it suddenly drops off. And then most people now contemporarily know that now the only open, you know, sort of infrarenal cases are being done on super young people, people with connective tissue disorder. But otherwise, like even across the country now, if you look at the last set of Medicare data, 90% of aneurysms electively are done endo now. So cat's out of the bag. This is the similar laparoscopic, you know, the lap versus open appy, lap and lap versus open chole, you know, argument. So noticing this, then obviously you try to scientifically look at some questions related to pushing the technology. And so, you know, things you start thinking about, and these are some early papers during my time with our fellows, and you know, looking at consecutive cases for standard things and figuring out what are the problems with it. So with any specialty and any change in how you deliver practice, I think those that are interested or that have busy practices or have the opportunity to look retrospectively back at things, you start to recognize patterns and you wonder, well, how can I improve upon this? And folks that are interested in sort of the academic mission are always trying to be on the cutting edge of being creative about how can I help improve practice throughout the country. And so these are some obvious things that many people in the room here that trained at institutions know that vascular surgery was going through. And this is a bunch of consecutive infrarenal cases and looking at problems with cases and how come things migrated, how come things degenerated. You know, endo, when it started with some very simple designs. They were meant to not have branches. They were meant to be placed in you know, areas where coverage of things, including lumbar arteries, inferior mesenteric artery, didn't have a problem. And so the majority of EVAR first 15 years is all sort of infrarenal devices. And then you have examples like this, and the vascular surgeons in the room know this is a migrated device. This is a degenerated proximal neck. Probably should have never been treated this way to begin with. And so, you know, the failure of proximal fixation became basically a thing that many people in the country studied. Like, why did endografts fail? There's a famous British Journal of Surgery article, kind of in the late 90s, you know, endo AAA, is it a failed experiment? Because there were many of our naysayers, many people that have gone toe to toe with Ben and Nitin and Matt and, you know, Sarah and myself at meetings over the years, like, have we gone too far with pushing this technology? And I would argue, as long as we thoughtfully push the technology, understood what its limitations were, that's how we're contributing to things. So yes, these are some obvious things. This is a long time ago, some of these papers related to realizing if you put it into larger necks that were already dilated, already partially diseased, you probably were going to have bad outcomes. And it turned out there was a 4-time incidence in this paper that we wound up looking at. And so a lot of people, including people like Dr. Starnes, you know, during the sweet spot of sort of figuring out issues, when we started staring at aneurysms and sort of realizing that the neck or where it needed to seal could be the potential problem, then maybe instead of just putting devices kind of right up to the renals, you obviously needed to get higher up and sort of incorporate the branches. And I know Dr. Starnes has slides where he's always championed this idea you needed 4 centimeters above the highest visceral. And that was his magic number that over the years, first people thought, well, that's too aggressive. Why do you need that much coverage and stuff? And now we have grown to realize the more of that healthy tissue that you're incorporating in it, probably the likely better long-term outcome. And so Ben and I honestly spent probably a decade going to every meeting, always as kind of the punching bag, counter punching bag about like the different techniques for sort of going higher up. And this is a tale of realizing something that I wanted to champion that to be honest, wound up being a failed experiment. Parallel endografting. And Ben remembers the number of times we were literally right after each other at the thing where I'd say, well, this thing works. And he'd say, well, this thing doesn't work. And that, I think what I grew to learn over the years is having a different perspective while feeling like you've got great sort of results with something. And I just encourage people as they come up with something creative in surgery to really find the way to wind up presenting it, collecting your data, and then finding that colleague sort of across the country that perhaps has a different opinion about it, and using that as the sort of leverage point for for sort of advancing the field. And so obviously these orange one is sort of the fenestrated concept, which then obviously has sort of won out even in my practice. And so I'd be the first to admit that, yeah, for a period of 7 to 8 years, yeah, I really thought this parallel endografting was a simple solution to something we didn't have. Most people acknowledge now that really only in a once in a blue moon, something bails out and you can't get something fixed. Would you even consider that? So we laid that to rest, sort of a while back. But then we even started realizing, and yesterday, Dr. Zetterval showed a couple of cases of even problems, even with what we consider now to be, the gold standard, even fenestrated branch things, where even if you put that into compromised tissue, that can be a problem. And so then this is a paper from one of our postdocs where we looked at just standard sort of commercial ZFen and also did the similar analysis of when you put it into things slightly on the margin. And I noticed Dr. Zetterval's case she showed yesterday happened to be a 36 millimeter ZFen. And those are the higher ones that fail. And it turned out when we looked at our thing, the composite endpoint of needing other sort of interventions, proximal problems with it, multiple fold increased risk of complications. So all that reminds us of, and somebody like Dr. Sweet has elegantly talked about this over the years at all of the national meetings. If you push the technology on the currently available devices, you will learn all of the failure mechanisms of that. So to the young people, as creative as sort of you want to be, within some guardrails and guidelines, follow some of those instructions. But if you're going to go off the beaten path, then track the outcomes and then be okay with talking about it and make that your platform perhaps for trying to innovate within our specialty. So then obviously then we've developed now, hundreds of different ways to treat these. And again, University of Washington has had years now of a physician sponsored IDE, both on the side of physician modified devices that Starnes set up and then custom made devices, CMD, that Dr. Sweet has access to. And now Dr. Zetterval helps with that program. And really Seattle has been on the cutting edge of all of these types of technologies. So kind of seeing all this in a landscape, and myself having sort of been trained and working for Ron Dahlman, who has had a NIH funded lab forever, obviously you sit around or you're mentored by people that kind of have a certain academic mission or goal in life. And then I started thinking, gosh, I need to figure out something NIH wise that will be compelling. And so this story, I think, resonates with a lot of the vascular surgeons in the room of like, oh yeah, I remember thinking that and this changed in it. But it really should be for anybody that's even not in vascular surgery, or anything innovative that you've sort of thought of. And then the question becomes, well, how do I make the NIH fund that? Because ultimately, if you decide the metric within academic surgery is external funding as a way to validate what you're interested in, which I still truly believe that's the case, then you got to find collaborators and stuff. This is Allison Marsden. She's now the chair of bioengineering at Stanford, and she actually was a postdoc fellow in the Charlie Taylor lab. And folks within vascular that have been around long enough remember Charlie Taylor's name on Chris Zarin's papers. Richard Charlie Taylor was chief of bioengineering at Stanford, and Alison Marsden was his postdoc. So we're fellows at the same time, and we grow to sort of collaborate on things. And she decides computationally to decide to look at all the crazy stuff that we were doing. So kind of on the side, she's following along, much similar in a way, seeing the relationship that her mentor had with one of my mentors. And we decided to be friends along the way at Stanford. And so very quickly, I realized, okay, you know, like I'm not smart enough to like do some of these computational things, but there's probably something in this to help us study it. So I'm like, great, I've got a research collaborator now. Let's submit something to the NIH, which should just be push a button and I should get funded, and then I can sort of accelerate academic career. And then now this is the tale of where things then go sideways. Now 2013, this is about 7 years into practice. And this is one of my first big submissions. And this is still perhaps, you know, semi-naively, you know, first decade of practice where I think, well, I got to do everything, right? I'm program director now. I got a busy practice. Now it's time to get my NIH funding. Of course, this is the negative letter that probably a lot of people in the room will get, because that's how the NIH is these days, about, you know, submitting, thinking you have a great idea, thinking you have these observations, you know, you spend a year writing a grant, you submit it, and then it gets turned down. And it just, I mean, people that have gotten this letter know that sinking feeling. You kind of sit back a little bit and you're like, screw them. Like, this is a great idea. Like, why on earth? Like, and it's such a cold letter too. And I leave this up here just because I sort of, as I was putting this together, like I wanted to make sure to weave in the story of like, as sort of enthusiastic as we are about science and things like that. But one thing that I say to all of my junior faculty, it's way easier to go do a FemPop than it is to go finish your grant. Because this thing took a year to put together. And then in one email, you know, whoever the company was like, just basically said, yeah, no thanks, the reject pile. And that's a frustrating thing. And for the surgeon scientists in the room, or for the budding surgeon scientists in the room, I would say how you react to this is make your grant better. Honestly, it was 2013. You know, I didn't really react that way. I just was like, maybe that's not for me. So then what I've learned over the years, this is Chris Cheng now, who's our PhD that's in our division. I guess I pivoted on that, decided, you know what, maybe I'm just not smart enough to get NIH funding. So you know what I'm going to do? I'm going to make sure I find smart enough people to collaborate with and augment their careers in that. And so Chris Cheng then joined us also as a partner of Alison Marsden, set up his lab. And now he's been successful now because of a lot of the clinical observations that we've made, contributing to the science and now working with the industry partners to help design next generation endografts. So then we had a cadre of postdocs and people that I started helping and supporting and teaching about stuff that I knew how to do well, complex EVAR and TVAR. And this is Kelly Hsu. She's now in the faculty down at Southern California in bioengineering, and we started looking at placement of endografts and some of the geometry. I mean, stuff that I wanted to get NIH funding for, but realized as soon as I funneled it through a PhD bioengineering person, they were getting grants left and right. And then you start to realize, okay, that's the other creative way to sort of contribute to this surgeon scientist model. This is Brant Ullery, who's in Providence in Portland. You know, we looked at different sort of deformation of things and created a model to study a lot of the complex interactions we were sort of treating and doing. This has gone international now. This is Johan Bondesen that's on the faculty in Sweden. And you find all these collaborators at sort of engineering. And that's what vascular surgery has always had, a cross-contamination with the engineers, and being able to spin off company ideas and sort of interact with them, and to let the engineering folks get their equivalent of sort of NIH funding. And so this has created for us in our lab the ability to where I can then, I mean now focusing on more sort of division administrative things, but to be honest, I kind of let that NIH thing go to really push some of the other folks that had time, bandwidth, energy, expertise in it, and that has turned out really well. This is for figuring out the geometry of why endographs bird beak. And so now Gore, that makes many of these devices, ask our lab to, when they're testing out new sort of concepts, being able to look at things like this. So kind of what happens with this is kind of the halfway point of this sort of discussion. As we innovate and push the envelope within any specialty, like what are the costs that come with this? Are there costs to both financially in a constrained system? And we happen to live and work in the US where I think innovation is championed. I mean, I live in the Bay Area where really you aren't successful till you make your own company. I think Seattle is another hotbed of innovation and sort of companies and technology. I've already hinted to what's the cost to open surgical training, and many of the educators Dr. Singh and I have debated and chatted about over the years at the Association of Program Directors in Vascular Surgery, and now Dr. Quiroga, about, what does that mean for open surgical training as we have pushed the less invasive option stuff? Can we even keep improving on these devices? Like, we change out the widgets fast enough where the outcomes for the last couple of years of that certain style, we haven't even finished processing the data for that. So how do we in real time continue to innovate? And then perhaps more importantly, and then this is Ron Dahlman's influence in my head now, like how about the basic mechanisms of why aneurysms even form? Like, are we going to spend now this next several decades just sort of fine tuning widgets and making the car a little bit better, or fundamentally deciding, is the car the best way to transport ourselves? And so these are kind of the philosophic questions. And this brings me to a quote that actually Tom Fogarty gave to me. So I was the last fellow that spent any time with Tom Fogarty. And he always said, when it comes to the future, there are three kinds of people: those who let it happen, those who make it happen, and then those who wonder what happened. And all I would caution people is, don't be in that last group of just wondering, well, why did that happen? I think that we all build teams of people that need to get the work done, people that help creatively make solutions to things, but don't be in that group that just kind of wonder, well, that just kind of passed me by. So this next half then goes over now kind of what I pivoted to the last 5 years. So this is Paul Bazuki here in the background here with a couple of my faculty members. And Paul hails from the Midwest, Minneapolis, and was kind of a rags to riches story in the textile industry, formed his own company, raised 5 kids, including a couple of people here that are on covers of magazine. This is David Bazuki. For those that have teenagers, you've heard of the company Roblox. It's sort of Minecraft for 6th, 7th, and 8th graders. It's a $200 billion company. And so David Bazuki, his brother here, Todd, and his other brother Greg, that's the CFO, in the garage came up with Roblox. Like any Silicon Valley story now, is one of the largest tech industry companies in the world. So how are they connected to vascular surgery? Well, it turns out when dad has an aneurysm, then suddenly get connected to folks like this. And so dad wound up getting a fenestrated endograft, had a short neck aneurysm. To be honest, it was easy. Like, for us, for anybody in the room, this is just your everyday case. But it turned out kind of afterwards, and I didn't realize or recognize any of this. My kids had played Roblox, but they moved on very quickly. They were like, oh yeah, Dad, that's for like elementary school kids. And I was like, well, the way they advertise it, it's supposed to be Minecraft after. And I thought Minecraft was elementary school. And of course, the kids will always set you right. I'm sure some of the residents are smirking about, well, okay, Roblox, yeah, that's maybe even for kindergarten. But anyways, $400 billion later, can't be wrong about Roblox. So anyways, this is Paul. Let's see if this plays. Gotta turn the volume up on this. Will this thing play out loud? Maybe not. Okay, anyways, that's okay. All right, so you know, Paul comes in for his post-op visit. It's like, hey, I really want to help you. Have you heard of this little company called Roblox? I was like, but yeah, I think my kids mentioned it at some point. I think at some point on my credit card is the Roblox dollars you have to pay for to buy stuff. Yeah, this is the Silicon Valley way of a company, right? Sell you make the app free, but then if your kids have ever gotten your phone, you get charged up Roblox dollars, and it converts on the exchange to lots of US dollars. And I was like, oh yeah. He's like, oh yeah. So my kids did it in the garage, and so I was the first investor at $1 million to Roblox. Now it's 400 billion. So I quickly do the math in my head. I'm like, oh, that's a pretty good investment in your kids, right? Wow, amazing kids you must have. And he's like, yeah, I'd really like to help you figure out, like, how do we get aneurysms? How do we make aneurysm care better and stuff? So it's just one of these moments. This happened during the pandemic of like, oh shoot, this is good fortune and good luck right at this moment. And so we came up with this idea really to set up the biobank. And so I pivoted on this because I had just been to some leadership meetings at Stanford with folks that a couple of you guys know, Joe Wu from cardiac surgery, Joe Wu, WU, cardiologist, past president of the American Heart Association. And we were sitting around a table and everybody had their own biobank. Cardiac surgery has a biobank. WU has his own cardiology biobanks looking at various sort of heart failure, rejection, myocyte regeneration things. And the group and the dean, Lloyd Miner, who's our dean, who's an ENT surgeon, the CEO of the hospital, David Ingle. So we're sitting around the table, and Penn had just created a all-encompassing biobank. If you visited University of Pennsylvania as a patient, you sign a consent that whatever sample that you get, they take off a little bit, they put it into this super biobank within the University of Pennsylvania healthcare system. And so Dean Miner's like, I think we should do that. And then, of course, then it gets mainly the cardiovascular sort of institute people into the room, and everybody disagrees about who should be in charge, because cardiac surgery always says, I want to be in charge. But cardiac surgery always steps in front. Cardiology is like, well, we're a lot bigger. We should be in charge. And I was just happy to be in the room. I'm in the corner of the table, like just going, and so nobody could agree on what to do. So we kind of shelved it. And then sort of the Bazooki family comes in and says, we got some money. What do you want to do with it? And I'm thinking to myself, you know what? Maybe I'll just start our own biobank. All of my mentors, Dahlman included, were like, dumbest idea, biggest waste of money you could ever decide. And then, of course, when your boss tells you that's the dumbest idea, sometimes you might be like, I'm going to do that. And so then I went and told both Joe Woos, hey, I was going to do this. Both also said, yeah, dumbest idea. Yeah, good luck. Okay. If you want to waste a couple of $1 million, go for it. Be our guest. Maybe it'll be one of those learning experiences where you fail at something and then you learn from it. So why sort of biobank tissue? And this now cuts across all fields of surgery. A lot of biobanks exist and provide valuable clinical phenotypic genomic data. I think specific to our specialty, vascular surgeons, we've always been a specialty that has thought about both the causative things, what happens intra-op, and then what happens post-op. And what's our thing? That we follow patients from the beginning of the process to their till they die. I think that we have access because we're all over the body to various vascular beds, right? So that's the thing. That's the answer when a high school student is shadowing you, or like an undergrad student, like, what is a vascular surgeon doing? How are you different than a cardiac surgeon or a heart surgeon or a neurosurgeon or a cardiologist? And so I always say, yeah, we work on the blood vessels all throughout the body, except in the heart, except in the brain. And so that you wind up being in all different beds, which to me is the intriguing thing about the science part of it. So if you can find the collaborative team to work with on clinical informatics, AI, machine learning, genomics, stem cell biology, health policy, cost effectiveness, imaging, modeling, observations, and clinical trials, of which each of these boxes we had experience in our division, then I realized, vascular surgery is primed to have a biobank. Now, what are the roadblocks as you have a pie in the sky idea? Often it's funding. There's just not enough money. Any junior faculty can go to Dr. Singh and be like, hey, I've got this great idea. Dr. Singh will be like, okay, good. Yeah, you let us know how that funding comes out. Because at the end of the day, time is our commodity that we have to give towards something. And honestly, funding often is the metric then when you show up in front of the appointments promotions committee about whether you should be advanced within sort of the promotion cycle. I think too many things are in silos or funded by individual NIH awards. And there's not really a standard for cataloging tissue, a central database model. I think with the electronic medical record these days, it's not been incorporated into some of the siloed biobanks that exist throughout the country and world. I think we have a lot of opportunity in our specialty. Think about the vascular surgery operations we do, or think about some of the general surgery operations that are done. A lot of tissue, blood is discarded. A lot of samples we take pieces off of people and we put it in the dumpster. The circulating nurse asks, oh, Dr. Singh, do you want to send that? And you're like, no, of course not. Put it in the trash can. We're not sending a piece of plaque for pathology for the pathologist to tell us plaque on the report. So I think we want, I also think our specialty can't think of all the uses of the tissue that we've actually sort of collected. So I wanted to leverage the strength of the wide variety of these patients and recognize patterns then for more sort of personalized care. So this is kind of how it works, is you collect the tissue. You know that our specialty has a lot of imaging we've already done. We utilize the electronic medical record these days to then create, if you will, a file, a catalog for that patient. And then I've decided for the vascular surgery biobank that we aren't even smart enough yet to know what the potential is of it. So rather than the usual NIH submission of, I want to study some protein in some piece of plaque, what are my methods? I'm going to get volunteer patients brokered through cardiac surgery, cardiology, and vascular surgery to give me 12 samples of blood and plaque from this population of patients. And then you spend years trying to chasing after surgeons to go get the samples and signing consents. So we decided to turn it around on its head and rather say, how about we build the bank internally, collect it from everybody, create a repository then for the scientists to come to us when they have thought of something and said, well, we've decided there's some pattern in carotid artery plaque for stroke. Can we get your last 50 patients that you have carotid plaque and blood on and study this? So we turned it on its end to hope that then other people would collaborate with us. So this again gets to that theme that I just talked about where I realized perhaps I wasn't smart enough to come up with that NIH idea, but I know how to collect tissue. We do a ton of operations and I can develop the workflow to collect this tissue, catalog it, and keep the records clean, and then let the researchers come to us. And hence we created the Bazooki family vascular surgery biobank. Now, the elephant in the room is always, and people have asked me this kind of privately later, well, how much did this whole thing cost? From soup to nut, from sort of beginning to end, we're 4 years into this now. We're $2.5 million. Yeah, all from grateful patient clinicians. Really, if you might argue for a Silicon Valley family with a foundation, it's rocking fun. But from an NIH standpoint, like you'd be celebrating your faculty who have gotten a $2.5 million grant over 4 years. So again, I just asked folks to be creative in this restrained administration we have right now with all the tightening of NIH dollars. Let's look at foundations. Let's look at creative ways. Let's look at people that we've treated and people that want to help advance science. So we now consent every patient that comes through the clinic that's having a vascular surgery operation. Collect the tissue, de-identify it, store it in a -80 freezer. We had to hire an infrastructure team to collect to sort of collect everything. And then we're obviously leveraging things like AI, the EMR, to make sure that we catalog the images and stuff with it. 3.5 years in, we just crossed the threshold of 500 patients put into the biobank. So full blood, plaque, tissue, EMR imaging on 500 patients. Okay, so what have we done with this? This is Najeesh Syed, who I hired. He's a cardiologist by training, PhD, MD PhD now on our vascular surgery faculty in our research line, meaning non-clinical. and now taking the tissues, having experience, making these iPSCs and studying interactions of cells in a dish. So this is the sort of disease in a dish model that he calls. So he's able to just honestly, with a sample of 10 patients, able to deduce some molecular mechanisms related to it. And to be honest, like 4 years on the faculty, he's already been promoted to associate professor. Three R01s funded already. A lot of it because he's basically told the NIH, and I have access to all this tissue and I can get it immediately. And so his ideas are at the NIH level able to garner some interest because he's got infrastructure built in. So I guess, like, I invested in setting up the infrastructure so that, well, really talented people like Syed could come in and within his first 4 years get multiple R01s. That's the ROI that I've been telling the family when they say, "Oh, what does this mean to you?" I get to help instrument the young faculty's career related to that. This is a New England Journal paper, or New England Journal of Medicine paper that he published just this past year. This is a Nature paper that he published, and this is our most recent annual research day with the family, and we gave them a frame thing of Nature paper that there, and this is right around so sort of some long COVID dysfunction in cells, that we took tissue directly from our newly made biobank. And of course, family wants to hear this, right? Okay, yeah, sure, you've collected 500 samples, but how does that affect science and stuff? And I think any family, certainly any tech family has heard of Nature, has heard of science, has heard of the New England Journal. And so being able to celebrate with them, honestly, just keeps this relationship going and stuff. Derek Claren, one of our young faculty that we hired, that interestingly, we just lost in industry. Actually, Derek was Mass General trained, came in as he called himself a vascular geneticist. To be honest, probably never really loved operating, which was okay. And wanted to look at multiomics. So took a lot of our tissue, blood, and looked at these GWAS, these genome-wide associations with different diseases. This is a Nature paper that Derek published just last year using the VA Million Veteran program, and the blood collected from that biobank, just as an example of these GWAS studies and how interesting they are. And Derek looked at thoracic aortic aneurysm, that had been studied well already for sort of abdominal. So he had a lot of plans with the biobank stuff. Interestingly, he got recruited to work for a private company that honestly attracted him because he's like, "Oh, you don't want to go through the NIH slow process to figure this out." And they just gave him access to data and money to do it industry. And this, again, I'm not poo-pooing that idea. I'm just saying that on that side of it, perhaps industry can get through these scientific discoveries a little faster. This is Elsie Ross, who just recently left our faculty, got her first R01 at Stanford, went to UC San Diego now. She was helping us in the biobank with sort of the AI EMR part of it, building up so that as soon as we put a patient into the biobank, the computer algorithm made into the database, grabbing the EMR data and making our catalog of it. And she's always, and so her R01 is in getting the EMR, looking for risk factors, and identifying patients that we should put earlier into clinic for screening related to PAD, aneurysm disease and stuff. So her ideas is precision medicine, right? The right patient at the right time, getting the right intervention. Everybody champions that concept. Lizzie George, that's on our faculty, that she's submitting her first K award now, looking at the health services side of things and screening and the appropriateness. And she started at the VA, she just moved over to the university practice now, but looking at the appropriateness of surgical interventions and leveraging the database we have of outcomes and then combining it with the EMR. And you can see how in any specialty you can translate these ideas. You could put a different face within your division of people interested in different things, all created because we have this biobank resource to help center some of the research efforts that the team is looking at. This is Ken Tran, who we just hired on, who had spent a decade with us as a medical student and vascular surgery resident, now looking at a lot of the imaging related to the biobank stuff that we've collected, and the application to complex EVAR and using Dr. Morrison and Dr. Chang as sort of primary advisors and looking at the application of fenestrated branch devices, differences in the computational flow. And maybe there will be a biomarker after he figures out the imaging that you can measure from the blood samples that we collect. This is Dr. Delarce Dubois, who was a postdoc fellow with us. She's on the faculty now in Lausanne, Switzerland, one of the most beautiful places in the world to visit. And she also spent a lot of time with us looking at branch versus fenestrated, and so some of the computational models related to that. What I felt like we were able to do was gather all these intelligent people to launch their careers from this Biobank initiative, from the access that they've got. Vivian Ho just graduated last year, spent also a decade with us, Stanford undergrad, Columbia med student, and then Stanford resident and research postdoc, looking at AI and trying to figure out screening and using the Biobank data for more launch pad, of ideas. Now she wound up taking a Kaiser job. Kaiser NorCal has a significant interest in population-based health. So she felt that that would be her best way in a closed system of Kaiser to study some of the things that she was interested in. Shaunak Adkar, who's our chief resident now, who we potentially might try to recruit, really looking at tissue to therapeutics and taking blood samples and plaque samples to really study it in mouse model to see if he can provide that. And so his first K award, hopefully, will use all the infrastructure from our biobank. So rather than that first K award having a lot of theoretical ideas, oh, well, I might do this, I might do that, he can actually leverage the 500 patients that we already have in our thing. John Cabot, who's in the lab right now, just figured out some of the genetics of popliteal aneurysms. John Cabot worked with Scott Dammerauer, who's at UPenn this year during his research time, and has won multiple awards, figured out one loci in this GWAS study associated with popliteal aneurysms. Those are very genetic studies. So, so then John comes to me and says, I think I found this protein. How many popliteal aneurysms do we have in the biobank? We do a little computer search. There's 12. Folks that know about these kind of GWAS confirmation studies, 12 is a pretty big N. For us, 12 in an N of doing something observationally would not provide any input, but we're going to take 12 popliteal aneurysm patients we have with their tissue and their blood that's frozen right now to study them, the one gene that he found novel, that's brand new, that people didn't know about popliteal aneurysm, that's distinct from people with abdominal aneurysm. And then finally, I think the person in our group deserves the most credit as our director of research, Nick Leeper, who we trained as our first vascular medicine fellow. So vascular medicine at Stanford is within surgery. I think I told a couple of people the story. Nick Leeper had finished cardiology, medicine, and then vascular medicine with us. The Department of Medicine didn't want to make a bet on it, did not bring him on the faculty. Ron Dahlman and Tom Crummell, chair at the time, said, well, we'll take a flyer on a vascular medicine person who doesn't operate to be in our department and division. It's a little bit of a gamble at that. Well, it's turned into 5 R01s, multiple R38s, which if you know what the R38 is, that's super R01. When you get an R38, you can never apply for an R01 again because your science is so good that it kind of blocks out all the young thinkers and stuff. So Nick now has spun off. They say at Stanford, you really aren't successful till you made your own company. And with Irv Weissman, with the folks that are stem cell people, one of the founders of the Regenerative California's sort of initiative. Now, Nick, as one of our faculty members, really taken charge of the T32 that then helps our residents every year in vascular biology get their 2 years of lab living. We have 5 spots every year within vascular surgery. And I was encouraging Nitin yesterday as he thinks about making the vascular surgery residency perhaps have a track that's a research track, collaborating with somebody else in the Department of Surgery that has T32 funding to, if you will, earmark one of the spaces to look at one of the vascular surgery applicants. There's so much to study within our specialty. We talk about the 6 Ps of vascular ischemia, and I'm sure I could quiz the med students and or the residents about the 6 Ps of vascular insufficiency, or what you're supposed to remember and recognize. So we came up with the 6 Ps for why biobank support: progression, prevention, personalization, prediction, prognosis, and policy. The theme of our biobank has been to use tissue to gain insights into etiology, progression of atherosclerotic and aneurysm disease, better understand disease progression. Prevention, the insights we've already gained from the analysis of tissue and blood and clinical data and the imaging allow us to better identify patients at risk for progression and development of these diseases. Personalization, if we can genetically figure out what somebody's likelihood of success with a procedure or an intervention is, that's the science behind stuff vascular surgeons do every day. Prediction, how do we predict imaging wise? And we talked about this a little bit yesterday. There's got to be something in somebody's CT scan or sort of anatomy to know that a branch construct works better than a branch fen construct works better than a fen construct. It's all in there. Most of us are doing it anecdotally or by observation or by pattern recognition or by experience now. I think we need to leverage AI imaging, some of our colleagues that are not vascular surgeons to help us with these answers. Prognosis, how do different phenotypes, if we discover some different protein markers in people, how do we tell them or educate them about their long-term need? We talked yesterday about patients we know that come in that can't ever follow up again. And I've learned about the vast nature of the Washington state geography where, you guys know certain patients come in, haven't seen a doctor in those 15 years, that patient you showed yesterday, shows up with a 12-centimeter aneurysm. We know we have to fix that. We know it's likely they're never going to follow up again, although that patient has come back. Right. So the point is that you want to sort of have good prognosis and predictive models for that. And then finally, policy. If you build a team related to all of these things, somebody on the team then can be the voice for how do we make some national decisions? How do we influence care across the country? How do we have our lawmakers provide reimbursement so that we're adequately compensated for the time and energy and intellectual capital and property that we build. This is how I now frame our research endeavors within our division. So we've had 2, and now we're going on the 3rd successful Bazooki Research Day. Scott Damrauer, who's professor at Penn, was our first one, 2023. Diana Milowitz, for those geneticists in the room, she's at UT Houston, came last year. And this year, Yulf Eden, who is from the Karolinska Institute, former chief emeritus of vascular surgery and creator of the largest vascular surgery specific biobank in the world. 10,000 patients in his biobank, 25 years collecting tissue samples, Sweden, perfectly cataloged. So if you ever have a chance to collaborate with Yulf Eden, great person to know from Stockholm. And then I can't do this in a vacuum. This is our Cardiovascular Institute leadership. A couple of you will recognize some folks. Joe Wu, former American Heart Association president, Joe Wu, cardiac surgeon, I guess next president of AAST in Los Angeles next year, a close collaborator. But a lot of people here that over the years have worked with perhaps many of you on sort of collaborative cardiovascular. So really, in conclusion, I hope I've kind of gotten people to rethink that in this era of limited funding, all the challenges that I think every division head, section lead, department chair, hospital manager, CEO, the top floor level executive thinks about. I think still in surgery, research and innovation is so key. I mean, again, so much easier to go do tomorrow's FemPop than it is to finish your grant. I implore the young people, go finish your grant. It's okay. Don't give up on it like I did. Or if you do, come up with a way that you're going to float other people to get successful with that. You got to combine what you love to do. I think people that know me well just know, yeah, probably at the end of the day, I loved operating so much that I probably chose to go do that instead of working on and sort of finishing that grant. But if you combine what you love to do and then be able to study that same pathology or direct a team that can study that, we'll be successful in surgery. I think we cannot in this era not continue to develop surgeon scientists. In 2022, there was a paper, Give Upchurch, who's a chair at Florida, looked up the data about within our specialty, and there's 1,091 NIH supported surgeons in 2022. There were only 51 vascular surgery So now I'm looking at the young crew. This is a path. You can find a way to be one of those NIH funded people. There's barely more than 1,000 surgeons with NIH funding in 2022 in the US. That number is going to shrink even more. Again, the majority of them are these folks that are in medicine and in other disciplines that perhaps don't also have to perfect their trade technically. But I implore you, that's going to be an important thing. And then finally, the multidisciplinary collaboration, celebrating team efforts together, telling the story of these young people, resiliency, compassionate patient care, which I think we all believe in, mentorship, sponsorship, having the opportunity to recollect on people that influence throughout your career. Those are the components to create an outstanding surgical group. And I don't have to look any farther than this institution to just think about, even though I've never trained or operated here, the number of times I've been here and the people that have been here that I've met over 25 years, it's very influential. So keep up doing the work that you're doing. And it's really been an honor and pleasure. So thanks for your time.
You have an opportunity to expand to first line relatives and look at blood and imaging of somebody you identify as a problem patient, well, not a problem patient, but patient with a problem.
That's a great question. That's the next step right now. Consent, everything these days within IRBs is sort of about consent. So we're able in our system to catalog everybody that's having an operation. Honestly, now that you brought that up, we should have built that into the IRB consent, that we could have also handed it to first line relatives and stuff. Obviously, you guys here for the cardiovascular, for the Marfans, or for the connective tissue group that you have here. I think being able to identify that or using medical geneticists as a specialty to help and collaborate with probably is the way to go. That one we haven't even tapped yet. Ours started as literally a grassroots effort within a thing. And to be honest, it got successful almost because I didn't start too big. I started with our clinic, people that basically had to say yes to me when I said, hey, we're going to implement this. There was no, hey, can we check if the nurses or the APPs feel comfortable, adding this to the workflow, right? Because they all had to report to me. I just said, this is our new initiative. And you can imagine if you start adding in other layers at the beginning, there's so many projects people start where it gets stuck in sort of the inertia that I think any large research institution has trouble with. And so I think one of my lessons was, again, everybody telling me there's no way this is working. And now 3.5 years later, multiple funding rounds later from the family, but starting to get some NIH dollars because we're saying we're using this instead of the NIH paying for the biobank things. I think it just spins off. So that's sort of investing in that to get the NIH dollars. But that's a great idea.
Dr. Lee, this was inspiring and also a little mind-boggling. And so the question I want to ask is, you've identified how much as a leader you can leverage the non-clinician scientists to partner with the clinicians. You've been able to embed them in vascular surgery. So my question, the question that I'm asking for Nitin and myself is, how do you manage to finance that? How do you where do the resources come? Because somehow you have to get it started. Once started, you can then sometimes perpetuate it as funding improves. But how do you get going to get those people to be good partners with our clinicians and accomplish the type of science that you've been able to do?
Yeah, no, I think that's always sort of $1 million literary question. Each of the scientists that we brought in onto the team, I think everybody knows in a department of surgery, you can't have too many of those because ultimately a department of surgery gets revenue from the hospital by doing surgery. So your question is totally spot on. Like, how do we get some of our folks that are pure clinical to buy into the concept that their hard work if you will, offsets some of the opportunity costs that the non-clinician is weighing down the sort of the finances at the end of the day. It's a tricky balance. I think what I try to do personally is that part of why some of our clinicians are so busy is because people will come to the institution because of the research innovation background. I don't think anybody thinks, if you will, they're coming to the institution in a vacuum. So I think telling the clinicians that the research part floats the ability for us to get the best residents, to have access to projects. It probably attracts certain types of patients who want to be part of contributing back to that. The bigger challenge is then, just like you said, at the startup, how do I pay somebody that isn't seeing clinic patients? And so that we have metrics where every year, and Syed's a perfect example. Like we brought him on. There's a little treasure chest that every division department has about spending on bringing in people that you know are going to lose money the first couple of years. And there's a formula where you figure out if by the third year you're not funded, you might have to close up shop. And there's plenty of examples in multiple departments of surgery, ours included, where I've seen people come in for research, get some $500,000 startup, and 2 years later, poof, they're gone because they never got it. Yes, so far we've been lucky. Syed turned his first 4 years into 3 R01s. He's now fully funded. That's a, Mary Han is like super excited about that. So that's picking the right people at the beginning. But I think it's also arming them with infrastructure resources that everybody bought into. Because Najeesh showing up as an assistant professor and thinking, and a non-vascular surgeon thinking, well, I'm just going to submit some vascular surgery grants on some disease in a dish. Like if you just had great ideas, the NIH, the study section people might look at that and be like, yeah, that's not really sustainable, or where are you going to get the tissue? Or it's going to take 3 years for you to find all the tissue and find all the clinicians. He puts right at the top, I've got access to 500 patient tissue. I'm going to start studying this tomorrow. I think that's why he got those minutes. I mean, I don't sit on study sections, but I imagine that's what's happening in limited resource now for that. So I try to, Joe Wu told me, and I don't agree with most things Joe Wu tells me, but he told me that you got to find a way where a paper done by one of the non-clinicians somehow floats the bonuses of the clinicians, and the work done by the clinicians somehow floats the research people. I haven't figured out that formula yet. He won't tell me that formula, but he said that that's a way to do it. I think each individual person, you have to be upfront with, if you will, what their role is. I guess I think of this like building a baseball team, to use a sports analogy, right? You need your leadoff hitter, but you need your number 9 hitter too to get off base, to get the leadoff hitter back up there. And those people, at least for my team, the Dodgers, that's widely disparate amounts of money that Shohei makes versus Tommy Edman, who's a Stanford guy. So.
Well, thank you so much, Dr. Lee. We're unfortunately over time. So for those who have questions still, you could come up, and for those who asked on the chat, I'll forward those along.